So Jake is a, da- a, a data science and a global health innovator with over 15 years of experience at, developing and deploying AI and machine learning solutions to address complex public health challenges. He holds a background in spatial epidemiology from the University of Florida, where his research focused on modeling outbreaks of infectious diseases, including tularemia in Ukraine and Ebola during the 2014 West African epidemic. As a founder of Hightower Tech and IT consulting firm, Jake leads initiatives that harness technology for social impact with a strong emphasis on equity, resilience, and community health. And with that, I'll hand it over to Jake. Jake, uh, over to you.
Thank you very much. Let me share my screen. Oh, let's not do the whole screen. That way you don't see all the notes, right? That'll make my life a little easier. Let's share the window. That way you can see. All right. Am I sharing the presentation now?
Yes.
Excellent. Thank you very much. Well, thank you for the warm welcome. It is really a privilege to be here. It is a tumultuous time to be an American doing global health, public health work, and focusing in equity. But now more than ever, we got to speak loud and proud uh, and share what we're interested in and share in this community. So I really, really appreciate the opportunity to be here to engage with this community. And I hope to get a lot of feedback and questions now and in the future in our Discord and our chats and our Slack. So let's get started. So in early of 2024, the WHO put out an announcement and it said, we are the WHO hub for pandemics, which is based out of Berlin. They specifically put out an announcement saying they were looking for proposals and they were reaching out to the broader community, academics, private enterprise, NGOs, the whole gamut, and asking, well, I'll keep my chat on too to see if I can monitor what's going on there. And they were asking for proposals, and the proposals specifically asked for building a decision support simulator for epidemics and pandemics. And I've watched a lot of the seminars you all have put on in the past, and I've seen some really incredible talent in academia. I'm not sure how many of you have really ever worked in the private space and worked in a position where you're not only building incredible mathematical models, but you're productionalizing them and try to put them into a front end system that users around the world can play with. For those of you that have, Godspeed. For those of you that haven't, it is a wonderful nightmare of complexities. And like many call for proposals, this one was particularly vague. And I'd like to say I have the joy of having a lot of experience and expertise building analytic models, particularly epidemic models, forecasts, time series, looking into the future. And I have a really strong idea of what makes good models. How do we assess accuracy? How do we monitor bias? How do we monitor those models over time? But this one in particular was fascinating because as the proposal comes out, what I'd like to propose to the audience, right, is consider yourself in my shoes. I have a colleague at Johns Hopkins, Dr. Tony DeBura, amazing man, incredible team that he leads. He gives me a call and says, hey, I see the WHO has put out a call for this announcement for proposals. I think we should throw our hat in the ring. Dr. DeBura has a suite of models that he has been pioneering. They're called agent-based models. They're very specific. We'll get into them in a minute. And he says, I think you and your team, this is at the last company I used to work for. I think you and your team and I could put together a really good proposal and we could have a really good shot. And of course, this is opportunity of a lifetime. Why wouldn't I go for something with the WHO? It's the pinnacle of opportunity, something I've always wanted to do. So yes, of course, we get accepted to send a proposal, right? So that's just the door opened. And now imagine, what is your proposal? There was very few guidelines, right? It should be a model. It should be something that can allow for intervention. It will ultimately be something that will work for many different, all different infectious diseases that could lead to a pandemic and certainly epidemics. It has to live on a platform of some sort, but that's kind of it, right? And this is to build a prototype, right? So not the full functioning, everything works out the gate, but prove that all the systems are there with a pilot of a few diseases and a few models and a platform that supports it. So you can imagine in the global health disease modeling world and public health, I'm thinking, okay, well, we have viruses, we have bacteria, they have specific transmission routes. Are we talking, airborne diseases, vector-borne diseases, arboviruses, spillover? Are we looking at intervention strategies? Intervention strategies change depending on the disease. Intervention strategies also change depending on geopolitics, right? My father was living in China, was in Beijing during COVID while I was in Florida. And so you can imagine the intervention strategies deployed as a Floridian, what we saw here, even as a Floridian compared to other states, and how our governor handled the outbreak as opposed to in Beijing, where they aggressively quarantined. And and then you think about the data complexity itself, and we could have a whole, not just hour-long conversation, but many days-long conversation on the complexity of electronic health records, case data, the lag behind when a disease is reported to when it's found, early pandemics where we're not sure what the disease even is, when you have influenza-like symptoms, when we're not sure if this is influenza or flu or COVID, right? When the COVID epidemic occurred. The statistical models themselves, what models, which, how are we going to monitor them? The model platform, how can we handle those models? Is this something that can be is fast and expedient? How many parameters go into that model? How interpretable is it by your community? The infrastructure that supports it, governance, PHI, security. Is this a simulation or are these analytical models of real data? Are users going to come in and bring their own real data of people sick and try to forecast where these diseases are going? The and then of course data equity across all of these verticals, all these pillars. There is the community we care about and the bias that is intrinsic to every one of these pillars that we just have to consider. And for me, was so incredibly important because when you create a proof of concept and then you move on to a prototype, that sets the tone for the rest of a project. It's success or it's failure. And in my industry, I find it's very, very important that we lead with the best foot forward. We set the right tone for future evolutions to deploy the right thing, right? So I just want to make sure that right in the front, I'm thinking, how am I making sure that this system is equitable? It can be used in all countries to serve all people. Really cared about that. And then, of course, I mean, this isn't all pillars, but just end with end user interpretability. And I like this pillar in particular because we made this proposal. We were really excited. And even when we pitched it, we got accepted and we're told to come to Berlin and do a proper pitch demo with some incredible minds over at the WHO and some CDC experts they had. And I just remembered asking, who do you think the end user of such a decision support pandemic simulator is, right? I mean, you say make this available to WHO member states. This is a platform that countries can use, especially countries that don't have CDCs, NSFs that can do incredible work. Is it the politicians? Is it the health departments? Are they analysts? Do they have expertise? Who's using it and how? And even that was met with a lot of, Well, this is a prototype, so we're not sure. So we had to do a bit of let's solve everything all at once. The ultimate proposal we came up with is this combination of a top-down and bottom-up approach. And for everyone here that does a lot of modeling, I love when I get asked by my friends and family that don't really understand what I do for a living, especially when they start to ask about AI and models. And a lot of times I get asked, is there a best model? The answer is always no, it depends, of course, but there is arguably a best architecture, right? And we would say typically an ensemble, right? Unless you have a very obvious thing you can answer with an incredibly accurate model, many different options we want, right? I'm a Floridian, so you think about hurricane models predicting where to go. And often I hear this expression, oh, I see all these different hurricane models saying that hurricanes might hit the south of Florida, the north, or it might do a U-turn. And then they'll ask this question, which one is best? And I always like to respond with, really, you should be asking, why are they different? Those models, right? They're not duplicates. They don't have slightly different data. I mean, some do, but for the most part, they're sharing the same indicators of pressure, temperature, rain, humidity, wind speed, all these variables. Why are they so different? And that's because the models and what they focus on and how they deliver are arguably a little bit different. And the sum of all those pictures give us a better representation of what could happen. And that's what we wanted to do here with this pandemic model is let's not build a simulator with just one model that we claim is the best because of X, Y, and Z, and then force everyone into it. Let's create a platform that can grow to support many different models. But right off the bat, let's take the two most common architectures and let's do the most advanced versions possible of them and deliver that to the community. So in global health modeling, we would say a top-down approach looking at all countries or many countries, many different regions at once. We would typically use a compartment model, right? We've all heard this before, especially with COVID, right? SIR models or ODEs. That's your top-down approach. And then the bottom-up approach is saying, okay, well, we can quickly and effectively look at disease transmission across the globe, but what happens if we zoom in? If we learn about these important factors and these important variables that are happening at large spatial scales, does that persist when you zoom in? Right? Too often we think about a strategy that looks at an entire nation or, the American equivalent of states, right? Those administrative regions. But what happens when you zoom into a city, right? Or a very rural township? How does that transmission change? And so the bottom up approach is an agent based model where you're going to simulate real people with real locations, with real demographics, and watch them transmit the disease and see if we can marry the two. And the discrepancies, the differences between the two is something you should never look away from. We should never be embarrassed by differences in those models, thinking like, oh, this is all model structure or error. Maybe it tells us it's somewhere to focus, right? So you can imagine, for example, in COVID, we focused a lot on, distancing as an intervention metric. And so maybe your global model say, oh, we assume that the transmission probability of a disease between two individuals is reduced by 5 to 15%, let's say, if those individuals are appropriately socially distancing. So a lot to unpack there, right? Averages of a probability and its effect. But then when you zoom into a real city and people are in an urban city, let's say like in New York or London, and they're trying to get to and from business and home, and they're having to stand at a crosswalk, are people actually preserving social distancing there? And if they aren't, these little exposure moments, are they having an appropriate, a meaningful effect on transmission? Does it effectively make null and void that opportunity of that intervention strategy? So that's why I like these two different models. We can not only model fast, quick, and effective with a top-down ODE, but then we can take those lessons learned and apply a bottom-up approach and try to ask those same questions. What we learn from the top down, does that persist in the bottom up? And what we learn from there, apply back. So it becomes this kind of circle going back and forth. I'll kind of blitz through these. We'll have hopefully, tons of time for questions at the end. So I'm happy to come back and answer. Just wanted to remind everyone, right? So like the compartment models 101, right? Uh, we call them SIR a lot of times because of the original notation by Kermack and McKendrick. Susceptible, infected, recovered. They're called compartment models because we're taking the population, our total N, and we're subdividing them into compartments that help represent the process of a disease. So, is everyone starting out as susceptible? Do they transfer into infected and ultimately recovered with many different parameters depending on the disease itself? So you got three sets of ordinary differential equations, right? And even to my non-math friends, I'm just like, don't let the notation scare you, right? This differential equation sounds great, but this is delta. This is a slope, right? We're just looking at change. If there's one compartment, if in the beginning of an outbreak everyone is susceptible, okay, what does it take for those susceptibles to become infected, right? Well, beta here is my contact rate, and I have to have a contact rate between my infecteds and my susceptibles and a probability for there to be an infection. And it's in this equation, it's negative because they're leaving with that contact rate from susceptible into infected. And similarly, we've got gamma, which is my recovery rate, and this is that group leaving infected and recovering into recovered. In this scenario, often recovered also hides deceased or from the disease. Okay, so there's your very basic SIR model, and it gets a little bit not complex, but just remembering that this is a time series model when we do forecasting, right? So you look at those compartments and we say at one time step today, typically we do time steps in days in a compartment model. The transition from today to tomorrow, my S's is negative this term, right? Because that's my contact rate to my infecteds divided by my total population. So that's what's left. That's the remainder. My uninfecteds stay susceptible. Those that did get infected become infected. Those that were infected have a recovery rate to R, and so forth. So there's these rate of change equations. I had to start there because it's going to get complicated. So for this proposal, we focused on a couple diseases. First, we focused on COVID as a respiratory disease that we're going to do with both the top-down and bottom-up model. We also do a vector-borne disease. We proposed malaria, and then WHO was like, do dengue. I don't have time to go over that, and that is a massive complexity that we also delivered on because you have to model the vectors themselves. So we literally have to create a model looking at the birth rate and movement patterns of mosquitoes on top of the people. So that's its own lecture in and of itself. So in the case of COVID, you can imagine there are many ways to model the transmission of the timeline of disease, right? So instead of just SIR, we could see susceptible, exposed, infected, and then recovered. Infecteds can become hospitalized. They can go to ICU. The hospitalized can become deceased. And even exposed, we call out exposed versus infected because of latency, right? With COVID, you could be asymptomatic. So it's important that we model people moving around in a compartment and persisting transmission opportunities as opposed to being infected. Because when we start talking intervention strategies, typically a lot of the interventions will affect those that are infected, and those that are exposed are it depends, right? It depends on social distancing, et cetera. So, uh, one of the things that we built, and the WHO just literally on Tuesday of this week did this release, the EIOS version 2.0, right? And that was their chance to show the world, hey, the pandemic simulator prototype is complete. We want to demo it. Uh, I sat there anxiously awaiting watching the video, and then the video audio cut out and the video got pulled and they had technical errors. So supposedly we'll be seeing a video of it shortly. So I'm going to keep watching and I hopefully can share their version of the video to everyone. But one of the things that we had to pull in favor of time and the prototype just delivering and making sense. Again, this is one of those there's a difference between choosing your ideal model landscape and all the features and things you want because you know they matter and you have to backlog some items. So one of the things we built that isn't in the prototype, but they have the code for, so I hope they deploy in version 2, is dynamic model compartments. So for those of you that have made these models before, this is a very manual process. You have to define these compartments, what the transmission parameters are from one compartment to another, any rates that matter. And I didn't want COVID to just be something you were forced into because this set of differential equations can work for really any disease, but especially, respiratory diseases. This same exact model architecture can work for influenza. It can work for, you know, um, COVID. It could work for, I mean, so many different respiratory diseases, let alone other infectious diseases. Even an STI or STD could work in here, but you'd want to change those compartments. So I didn't want to force the user to just click and this is it. You have to have these compartments. For example, hospitalization might be important, but maybe a metric that a decision maker really cares about is intensive care units, right? ICU admissions, and that is the piece that gets overwhelmed during an outbreak, and we need to make sure we're allocating money appropriately. But many countries don't even have the technical resources to monitor that, so it wouldn't be important to add that in their model. So one of the things we made that I was trying to demonstrate here, I don't have the visual of the application we built, is dynamically delivering these ODEs so that there's this base model, this SIR. In here, I'm just showing SEI, but I'm showing you can click and drag and automatically deploy new dynamic compartments. And that might sound simple, but it like logarithmically explodes. The more compartments you add, the nodes, how they connect, what parameters. So being able to automate that in an intuitive way so that you have this graph at the end that you can very quickly fill out what parameters and where made it a really seamless experience for those of us that have had to code this by hand. So I really hope we get to see that in upcoming releases. Okay, so what's the problem with traditional SIR models? You're probably thinking to yourself, God, please, Jake, don't tell me this whole thing is you did an SIR, right? I've seen a million of them and they're okay. Well, one of the main problems, right, is homogeneous populations, homogeneous mixing, right? So what you can see here is like very traditional of SIR models where we assume that this is your population, they exist in a vacuum, it's a perfectly bounded box, and your population just bounces off one another, and that's it. There's an equal opportunity for all individuals to mix. That's not particularly realistic in an outbreak. Oops. Next slide, not click. There we go. So what I wanted to show is the mobility model. So in the application, you can choose any country you want as a starting point. From that country, we were pulling from, speaking of geopolitics, we are pulling from different administrative zones, right? So how does a country define its borders? Not just the country border, but we call them administrative zones. So admin 0 would be your country, and admin 1 for the United States would be a state. Admin 2 for us would be a county. And then you can get finer and finer resolution. So the user can come in, choose a country or countries, choose a region as a starting point and say, hey, I want to focus here for my disease. And my point is that what we were able to build is for the finest level of spatial resolution that you've chosen. So if you're at, let's say in the case of the US, admin level 1 between states, or maybe you want to focus in, I want to focus in on Florida specifically. I can zoom into Florida and look at counties and diseases moving between counties. So rather than just all of Florida and everyone ping pongs in between the entire state, that's not very realistic. In fact, I have a higher probability of traveling from Florida to London, especially in my history, than I do going from Florida to Miami. So why and how do we demonstrate that? So uh, Lisa Sattenspiel in 94 did this awesome paper for SIR models, but essentially it took these simple ODEs on the left and complicated them on the right. And I wanted to break down one just to show how simple it really becomes when you zoom in, right? So we had this simple term before, and all we've done is say we got to let people travel. And if people are traveling, so if I'm at region I and I want to travel to region K, once I get to region K, eventually I'll come back. And that's its own parameter. How long do I travel for? But the rate at which people come home and the rate at which people leave are often not equal. And if they're not equal, we have to turn them into two equations. Boom. So now I've solved why that first equation is now two equations. We have to model people leaving and where they're going, and we have to model people returning back to their home. And then essentially you can say, well, there's this return rate. So in my first equation, my people that are home, that are gonna leave, I've got a number of residents returning home, and then I've got the number of residents leaving on a trip. And then I finally have new transmission events, which will pull these into my infectious group of those people that are about to leave. And then I do the same thing, but look at the susceptible residents who are visiting other regions. So I now have to calculate Jake lives in I, but I'm traveling in K. And while I'm in region K, am I going to get infected? Because it matters that if Jake travels from Florida to London, I'm not interacting with people, obviously, in Florida. I'm interacting with people in London, and I need to take that contact matrix and interact with it and make sure that I take my transmission status home. So that's essentially what's going on here. And we do that for every one of these compartments. Okay, so we've got mobility. I have in the appendix also how we do that, and then what pulls people from one location to another. In this scenario, we use a gravity model, but I don't have enough time to go through it. So we further complicated the SIR model because it's not fair to call all people equal. And this is where we start to get into equity. And scratching the surface is we started with age stratification, especially age stratification and contact rates, right? If you say, oh, there's a million people in region I, and even allow those million people to move around subcompartments, right? So, a county or whatever you move people, the contact rate between an adult and a child is not the same between a child and a child or a child and a senior citizen, right? An elderly. And those are really important. And the more we can impose on these models to genuinely represent realistic populations without endlessly digging that hole, the more accurate, the higher fidelity these models will have. So there is, let me get the name right here. Yeah, Ma Song et al. Social Contacts and Mixing Patterns. There's a really great paper. One of the colleagues at the CDC in this project turned us to this. And essentially, they did all the heavy lifting of looking into what those contact networks were between different age groups all around the world. So we could literally pull if the user logs into this prototype and chooses the UK, we can pull UK specific contact matrices between adults, children, and the elderly, and use that so that when we're pulling realistic demographic splits and age groups, we know what the chance of those people coming together are, right? So again, if a field trip of students travel from one region to another, elementary age students, they're going to behave differently than an adult group of people traveling to the same location. And it's important that we capture that at least to some degree. I think the other thing I really want to make clear here is I'm really excited about this work. I think it's really pioneering. At the same time, it's not perfect. My goal here, our team's goal, was to build a prototype that is open source, open for the community as a framework, a foundation to build upon and to insert new metrics of equity that make sense. Really understand, okay, well, you're getting the beginning of understanding of age stratification, but it can get so much more complex. The other thing to keep in mind here is because this is a compartment model, you can really only add so much complexity before you start to ask, should we just create an agent-based model? right? So remember, these have different goals. And part of the goal of this compartment model is to make it robust, but I also want it to be fast and efficient so that if decision makers are coming in and they need fast answers, they can quickly run dozens, hundreds, hopefully in the future, thousands of runs, right? So they can understand a distribution of outcomes and then compare that to the tens or dozens of runs they're going to be able to get from the agent-based model because it is so much more complex and costly to run. Okay, so let me show you something real here. This is in at least in one of the current versions of the prototype that they are releasing to member states. So you can see you've logged in. You can see at the top here simulation configuration. So you get to start out saying, okay, what does the interface look like? And as someone who builds models for a living, as someone who's been a data scientist, I really wanted this platform to be targeted at epidemiologists, health professionals with an analytical understanding. I wanted them to build and run the models. And then I wanted the output to be something that could be configured to be very interpretable to any level so that they could tell leaders and the decision makers who have the deep pockets, hey, I ran these important models. They're all statistically sound and valid. Here's a visual and understanding you will get. What should we do next, right? Where do you want to? Here's all these intervention scenarios, right? Which should we choose? We got a lot of kickback from that. And I'm not just saying the WHO, and they're phenomenal partners. I mean, tested across lots of different groups. It really seemed like the push was to make this an application that anyone could run with or without knowledge. I will leave my opinions out of that for now. But as I go through the complexity, you start to have to ask yourself, what is the utility of deploying some of the world's most complicated models if the user has no idea the extent to which they could misuse it, right? It reminds me a lot analogously of kind of large language models right now is everyone is using it. Almost most of the population doesn't understand the framework by which they're built and their limitations and how that can mislead the user. So something to consider. So you can choose which disease you've got. This will grow to cover all diseases. Like I said, we started out looking at respiratory pathogens and vector-borne, the vector-borne being specifically dengue. There's some fun conversations on simulation IDs because we want these models and their runs to be repeatable. So the simulation ID stores everything I need in order to rerun entirely that model so that when you finish a really fascinating model, those results can be stored and recaptured if someone else wants to run it or take that model and apply it to their region. That sounds simple, but these models can be both, this one can be both deterministic and it can be stochastic. And again, for those of you that have built models before, you know that's not as simple as storing a seed. Even things that you think you store a seed often will still pull random. So there had to be a lot of bumper lanes installed to make sure that results were truly repeatable when called. So the user can come in. I want to model COVID. I want to choose a date range from when it starts. They can choose their locations. They can fly around the world, highlight a region. You can see what I was saying before about here, admin zero. So what defines a country? We're using the WHO definitions. So you remember my pillars talk in the beginning. Geopolitics, incredibly important, right? Imagine Palestine or Israel wanting to do a model right now. There is contested territory as even trying to be neutral, even genuinely caring about the whole world and wanting everyone to have access to this to help the entire world community fight diseases. What maps do we use? And is there conflict by using a certain definition? So it's important that users can upload their own definitions, you know, politics be damned and our opinions aside, for us to be able to run important models and share information to the broader global community. So the state right now is being defined by the WHO's definitions of states. Admin one, so those that first layer down and geospatially, we're using the very popular GADM, and then you can see demographics. So there's again, this is prototype. There's so many different ways to peel this onion. We just really wanted to show that this is incredibly doable. But how do I take information from a user? That could be case files that someone drops us that has information. Oh, we're 3 weeks into an outbreak. We want to start from today and forecast forward. Or we're doing a hypothetical. We have no one that's sick right now. So we're showing here you can break out the percentage distribution of those different demographics, but a major part of this is the ability to drag and drop case files and work with forecasting out based on real data. Of course, that just again begs the question. And one of your past talks I watched, even just the differences in EHR between the United States and the UK, right? What is a case? What is a case definition? What is its name? What dates are we using? Are they the same? So there's a lot of uniformity that would need to be ironed out for us to go from prototype to deployed production ready for the world, right? But data can be handled. Travel volume. So you see what is the percentage of population crossing between different administrative units? So what is the chance someone will travel? We can call that discrete, but obviously you can imagine there's so much opportunity to make even that better, right? Things like tourism that we don't account for yet. And then the custom simulation. So here you can see what I was saying before is we are calling out this susceptible, infected, recovered, these specific compartments, and they have to check them yes or no and then define them. That's a piece that I hope in the future will go back to that dynamic modeling so that users can make whichever model they want. You can see here, I'm talking about that case file. This is something you could upload. These are the different regions, Senegal, their population. We're auto-uploading population estimates. That's something the user could change as well. And then initializing infecteds, right? Who is infected? Is it distributed equally across every region as a scenario test game? Do we have real case files where only one region or several regions are infected? And then, like we said before, there's all these, this is where I'm like, where's my Greek methodologies? Where's my betas and my gammas and deltas? But it makes sense to make this as intuitive as possible. And even then, this is a prototype, but I'm really proud that these parameters are visualized here so that people can understand, oh, what is the case fatality rate among hospitalized? What is that chance to go from hospitalized to deceased? We can put that in there. And then at the bottom here, the interventions, which again, there's so much math and complexity even behind those, and all just kind of summarized with a sentence, right? Are we going to do mask wearing, vaccination, travel restrictions, social isolation? And then you can review, and then you can output show the output. I might have to drop that back in there if I didn't show it, but case curves. I'll make sure I pause at the end and pull that up. But the outcome is those SEIR case curves. I'll definitely pull that up. I apologize that I must have pulled that. Okay, so that's that top-down approach. So I want to flip the script real quick and go into the agent-based model. So that's Dr. DeBura. He and his team out of Johns Hopkins have been working on several different strategies for these agent-based models, right? They're fundamentally different in that they look at individuals and their mobility and their contacts as opposed to large compartments. We broke that model up. We built this from the scratch into these components. So POIs, households, the details about those agents, their mobility, where are they going, and then managing the transition of disease, right? So we call that disease management platform. So POI is pretty fascinating. The agent-based model has millions of real points of interest. So before where we were modeling diseases all at a high surface level, where we're starting now is the same way that you would Google, Bing, Edge Search, MapQuest, right? When you look up locations, we're scraping those exact same locations. So when you want to go to a local restaurant and you're trying to figure out, oh, what time does it open? How expensive is it? That same API call that you're doing on your web browser, we're pulling, and we're pulling through Mapbox. So what this does is for a given region, we have different categories of POIs. So, food and beverage, hospitals, schools, and then the real name and feature. So this is really pulling from one of those features. I can see where it is in latitude and longitude as coordinates. I get its name. I get a class, what kind, a category of what type of POI that is, how many people can occupancy, things like that. So I start by, as the user, you said, I want to do an ABM and I want it to be in this region of London, let's say. Great. We pull an API to go fetch all the different POIs that we have pre-scrubbed and filtered so that they're more in alignment to a disease model, right? Important POIs that people would go to. I say that because it can get really complex with the POIs having things like mailboxes. There's things that people wouldn't traditionally go to that is in that data set that we need to scrub and filter. And then, so I've initialized all these different locations people can go to. Great. What now? Well, we need, I'm here to talk about equity. People, I need people and I need to know who they are. So originally, I wanted to synthetically make them myself. But again, one of the really smart minds from the CDC that was working with the WHO mentioned in 2024, they finally released the Harvard Dataverse GlowPop S dataset. And they did let's see if I have the description up here. I have the paper. I can walk people through it, but essentially they created this robust global data set that goes over the entire world that pulls from different prior studies and does projections forward to create households that respect the expected demographics of that country based on surveys and census and other information that are traditionally accepted as de facto as norm for that country, right? So we've got real demographics we can pull from. Now, again, huge asterisk of they're good, they're not perfect, right? And they're not, it's not like I'm pulling directly from EHR, but it's an opportunity for us to not only pull from households, but that could be something that future member states want to drop themselves. But we got to be careful of privacy and all that. So the point is, I have households. So I have a number of households that will then make up the appropriate proportion of population. So if you said you're in this sub-district of the UK, and let's say that area has 50,000 people that you want to model, and we sample without replacement from the Harvard Dataverse GlowPop S dataset to get the representative sample of houses in that region that have the appropriate demographics. So they have things like this PID that these are different households, and HID PIDs, these are my people. Relationship, there's a head of household, partners, children, there's income, education, age groups, and then there's so much more we can add as well. So I have people now. Once I have the locations, the POIs, then I have households. I haven't put them anywhere. I just have a table of households. I can then create agent details. Um, this is really an awesome opportunity to create people and move them around in the location. I think for brevity, I'll kind of slam through because I really want to get the chance to answer questions. So the point is, we make these agents and we assign them. We assign them where do they work, what home do they have, and then through the next step in mobility, uh, I also create full on trajectories of where they go every single day, every hour. So I have real people, well, synthesized real people and synthesized realistic households with real points of interest. Those people have jobs at real workplaces and they drop their kids off at real school, they go grocery shopping, they move around. I have hour by hour what those individuals are doing. And then the last thing we have is the DMP, and that is how we look at transmissions. Like, do people get sick? And so we use this Wells-Riley equation, but the key here is I just wanted to show, right, is if I have a person in blue and they are at home and then they go to work and then they go somewhere else, and maybe they stay a few hours at work. What the Wells-Riley equation allows us to do is a different person might also come to that location and come home. And that's their pre-computed trajectory. That's what we expected them to do. Now we simulate diseases. And if that same blue person was sick, they're going to allow that disease to temporarily persist in the location, right? They coughed They coughed up aerosols. Those aerosols can persist with a time decay in the location that they were at. Now, when that green person shows up, if that probability die is rolled and they do get sick, we update their trajectory so that instead of going home, they're now sick. And maybe they go home, but as they get profusely sick, they might instead change and go to the hospital, and it changes their future trajectories. So you can see now the iterations that have to happen. We simulate all people in all environments, where they're going, and if everyone was healthy. And then once we start seeding sick people, this recompute of what happens as people get sick, when and how does their trajectory change. What's great about that is it allows us to focus on what kinds of locations are crucial in transmission events, what kinds of people were affected, what age groups, all of the agent details that are important in disease transmission can be preserved there and summarized. So there's a ton I could go through. I meant to stop even earlier, and I'm sorry I got so far, but this is just something I'm very passionate about. So let me stop there to answer any possible questions. Thanks for coming to my TED Talk and rambling.
Thank you so much, Jake, for this presentation. And I invite everyone uh, uh, who's here to chip in with their questions. And uh, I'll just, kick it off, So this platform you said was developed for the WHO pandemic hub, right?
Mhm.
And I'm just curious, what has been the reception to it so far from, for example, ministries of health and these public health officials, and what has been the biggest barrier to adoption for
Mm.
the current and maybe the future pandemics too?
No, I appreciate it. So and I'll be clear, right, is we built a proposal and ideas and then pivoted a ton with the feedback we got directly from the partners at the WHO hub and CDC counterparts. So, I mean, I'm happy to say that I was a major part of the development with the team, but we were guided a lot by the the kind asks of the WHO. That said, it's still a prototype. So their release literally yesterday was supposed to be a release announcement for member states to start more actively participating. So we did a QA/QC. We released this internally with volunteer members from the WHO, and I think they released it to some other member states to get feedback initially. And honestly, the clear number one winner on barrier right now is complexity, right? And we've all seen it, right? Every one of these presentations is model complexity, and the math behind really important models are important. The nuance of one variable and and its variance can drastically change the outcome, especially since the goal of this thing isn't just forecast what will happen, but then look at, was an intervention strategy effective, both in saving lives and cost, and really thinking about how do we deploy them. And there's this major effort to, I'm going to kind of say dumb it down, but make the platform simple for decision makers to understand. But then there's this trade-off of, but then do you lose mathematical, acuity and accuracy? So I think those aren't answers that they have to have today because it's still a prototype. The models are there, the capability is there, but the user interface, as simple as that sounds, is super important, right? That journey of how users utilize the prototype effectively, and how they want to launch, right? Do they launch predominantly to decision makers? Do they launch to analytic teams and do more demos and provide training? And I think that's a major part of what they're going through right now.
Hmm. Thank you. We had a hand raised from Vanessa. Do you want to go ahead?
insights on this journey of this project. And I can definitely tell it's a passion project of yours. I was just wondering about the agent-based models. Is there any way of sort of simulating maybe a difference in an event or something, an occurrence that is out of the norm? For example, if you think of the Olympics in France last year, would there be a way of simulating that as well?
Yeah, and this is when I don't have the time to show, and I just want to open the hood for all of you. So again, open source. So please reach out to me so I can show people code and walk them through scenarios. Everything has been parameterized. So from a front end user, you say things like, "Oh, we let people move." From the back end, I have things like, "Is the transportation rate through car, bike, or walking?" and that I mean there's so many interdependencies that can be done. And so what my hope is, as they open this up to the community, that people will start to do exactly that. Be like, let's play with a scenario, a unique scenario like an Olympics, and say that traffic is cut down and therefore mobility is slower and more congested. And again, parameters, right? That's a knob on a dial. And what is imperative, again, on that, especially on the equity talk, is that any of the models that we use, what we're making happen is that when that simulation ID runs, right? When Vanessa says, I ran this model and I'm going to call it Olympics in the UK, all the metadata, all the parameters, and your notes are carried with that model ID. So you can say things like, I simulated Olympic congestion. These were the parameters I focused on. And that, I think, is a major thing that we don't, that is lost in a lot of like academic publications. You get these really dense publications, but like the TLDR that like modeler to modeler needs to know is, hey, in this one scenario, this non-perfect model, I attempted to replicate the real world of congestion around a heavy event by changing these parameters. Here's what I saw. Here's what I think worked. Here's also what I think didn't work. And persisting those notes in the platform. So then Awaz, myself, someone else can come in and go, oh, great idea. But what if? Like, that's really what I hope for this platform, is that it can create momentum for researchers to improve and create better models. Excellent question.
And uh, is there a repository that we can take a look at, or
I'm waiting. It's the WHO has it. I have the code I deployed, but I'm waiting for the WHO to make its official reveal. The project is defined as open source, so it just depends on when they're going to make that open to the public. I assume imminently with their release, literally, what, Tuesday,
Mhm.
of this EIOS version 2.0.
Sounds good. We have a Matt right after this.
Thank you. And Jake, thank you very much for the presentation. I appreciate how you translated a lot of the more technical and mathematical terms into something that even a more humanities-based background individual such as myself can understand. When we're looking at the health equity side of this, especially those inputs for such nuanced underlying models that you're talking about become incredibly important. Uh, in terms of, what would you say are some of the, or have there been any challenges called out early on in terms of data sources, qualities, or standards that are feeding these and potentially impacting health equity outcomes positively or negatively, understanding that that can, go either way.
Yeah, sorry, I'm brown nosing all the audience, but another excellent question. There's a reason that there aren't more equitable measures launched in the prototype. And that, of course, has to do with consistency across the globe, right? Because it's a global platform that needs to work everywhere at launch. And then even how those metrics are taken. And as you can imagine, there's both an opportunity to leap forward in progress and help monitor really significant issues, and the opposite. Again, cough, as an American, there is such an opportunity to use this in a negative way. If you, especially if the users don't fully understand, oh, I'm adding in race, ethnicity, you have the capability to make this a simulation, right? Are you getting that from case data and you know the relationship between your agents, those individuals, and those outcomes? Or are you just willy-nilly saying, I'm going to assume all white males have a higher propensity of the disease? What happens? And that's the good news is the WHO really understands that. And that's why I'm excited about it being open source platform. I mean, my hope is that there's a whole equity community that comes in and just plays with how do we make this make sense and how do we call out when it breaks? Like that's the first thing I do in these kind of applications is do something that gives us non-realistic outcomes so that we know the limitations of the current models. Um, so without going on for forevermore, yes and yes.
We have two questions uh, on the chat about its applicability to non-infectious diseases, and then Nikem has a question. So uh, let's just take both, and then we can wind up. Okay. So
Yeah.
Nikem, if you wanna ask yours.
Okay, thank you, Jax, for your presentation. It was really insightful. So my question is just basically concerning the back end. Is there going to be another section like to put us through the process of building the models and all of that? I don't know if I'm asking too much.
No, can you restate? Is in the back end, is there a process to what true? I'm sorry.
Yeah, I said, is there going to be another section like this to just put us through how you built the models?
From me. Uh, there isn't planned. I am happy to do another and just dive through code. In general, for everyone, like it says there, I'm very good at responding. So if you message me at jake@hightowertech.net, even one-offs, I'm happy to walk anyone through. I was lead developer for all the models, right? I have all the model code, what we did and why. Happy to walk through. And I'll reach out to the community, especially on the Slack channel, the moment I see a GitHub release, because I know that's the most important is let's dive in. And please, I encourage everyone to. The WHO also has a group called the Collaboratory, and you can join up there. So you can start to say things like, I want to see these changes in models. I want to see these opportunities. And then allow us to answer the non-infectious diseases. Yes, I do think it can be applicable. It's hugely nuanced, right? I mean, it depends on the disease and why, right? There's lots of proxies, right? So, like I said, with like a sexually transmitted disease, you can't just assume because of proximity of people that a sexual interaction has occurred, as an example, right? So it's not as simple as just saying, oh, I'll reduce the probability. But the fundamental framework is there. So I would say somewhere between 30 to 80% of the effort is already done for non-infectious diseases that could be used for many other diseases. But you want subject matter expertise to weigh in and people to meaningfully manipulate those models. But that was the goal, as you'll see when you do end up looking at the code in the back end. We tried to make things in chunks and segments to be editable, not a cluster of code that is non-intelligible that you can't comb through. The goal is to edit, improve, delete. Um, and I hope we see that.
Thank you so much. And yeah, I mean, we will explore opportunities to engage with you more. And once, I mean, the source code is available, we can see what's
Right.
possible down the line. And with that, I want to thank Jake for his time and a detail for in going through the model and uh, hopefully sparking some ideas and conversations that we can follow up on. And yeah, we'll see. Uh, 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 hopefully, some of you next month for our next webinar. So be on the lookout for more information. And I hope you all have a good day.
Thank you.
Bye.